We are way ahead in understanding actually biology of the disease when you compare with our ability to manage patients. We have 2 JAK inhibitors in the United States that are important for control of symptoms and the spleen, but not much else. We just talk about luspatercept, maybe anemia drug, and you can combine those, right? Or we talk about CPI, epigenetic genetic modifier or modifier of genetic expression, maybe adding to JAK inhibitor to have more of a spleen and symptoms control. But none of these therapies is specific for malignant clone. And how can we devise the patient's therapy that would eliminate the bad cells and not touch the good cells? We have not had anything like this so far. When we dig into the basic science sessions at ASH, one of the abstracts stands up. And this is development of antibodies. These are proteins that we all have in a body that are made up to attack what we don't want there to be, like a cancerous cells or infectious organisms. We have in basic session a report on the antibody development for malignant cells in myelofibrosis that have expression of a calreticulin protein. What is calreticulin protein? It's specific mutated protein that is seen in about 30 to 40% of myelofibrosis patients. And by devising the agent that would specifically bind to the cells that have a mutated calreticulin protein, we would envision that in the future, in these 30 to 40% of myelofibrosis patients, we will have specific targeted agent for these patients to eliminate malignant clone. That would be really, really something novel because we have never, ever had anything similar.